She's a distinguished James McGill Professor. And she's going to talk to us this afternoon on trials of complex interventions, what, why, where, and how. And for those of you who were not here earlier, I can share how I met Nancy. We met in New Zealand. We were sat next to each other, and I was a little grumpy, possibly because I'd just flown over from the UK and I was going to New Zealand for literally a weekend. And I sat there, but also because I hadn't got funding to a follow-on trial. So I'd done a small, I think, feasibility or pilot trial on exercise, and then the UK, the NHR was not interested in following it up. And I sit down next to Nancy, and she goes, "Oh, it's you." And she had just got a big fat amount of funding in Canada following on from our pilot trial. So with that, I shall pass over to Nancy. So thank you, everyone else.
I was literally looking at this paper, and it was this Johnny Collette guy. And then I look across, and then on the senior author is Dawes. I look next door, and there's a Dawes. I'm going, oh. And I used her paper.
I'm still not forgiving you.
Yeah, to argue for my trial, and we got it. So that leads us into a trial, and I'm actually a trialist. Although I have to admit somebody, do I? Or are you admitting them? Okay, I don't have to admit it.
Yeah, thank you.
So I'm actually, my training is actually as a physical therapist, but very early on in my clinical career, I did epidemiology and biostatistics and did a lot of trials, trained as a trialist. So at McGill, I do a lot of consulting and methods, and I don't work in the pharmaceutical world. I work in the very, practical world with rehabilitation interventions, behavioral interventions, and it's all a mess. If I had a drug and a placebo, I'd be the happiest person in the world, and one single outcome that you measure in the blood with no error, I would be perfect. But my world was this very messy world. And, I had to learn about how to run complex interventions a little bit by the seat of my pants. And now I've been able to put this together. And in fact, we've designed a course that I'm going to be teaching, even though at my advanced age, you'd think I would not. But I've heard that the Faculty of Medicine really wants you to teach this course in 2026. I'm going, oh, thank you. So we'll have to see how that works out. So just to give you a little bit of a conflict of interest is that I am president and CEO of a company, and one of the trials I'm going to talk about is from my company. So that is a bit of a conflict of interest. So let's start with something simple and say, what is a complex intervention? So complex interventions have several interacting components, as you see. But of course, there's more to the story than just that. So they're complex because of the number and variability and difficulty of these interacting components, both the experimental and the control group. Behaviors are required, both by those delivering and receiving the intervention. Groups or organizational levels are also targeted, and that can be the participant, the care partner, the healthcare provider, and the care contexts. And there are multiple outcomes, and the interventions need to be tailored. In this complex world, there's not one size fits all. You have to tailor the intervention to the person. So this makes studying it very complicated, and that's why there's this new framework for complex interventions. So let's look at how complex is. So this is actually the part of the concept map for my new course. So when you put in a new course, they want a concept map. So I made them a concept map. Then they complained that it was a table and not a concept map. I said, well, just too bad. This is what it is. So when you're looking at these interventions, first you have to say, what am I actually trying to do here? Is this an intervention at the diagnostic level, at the preventive level? You're trying to prevent something, you're trying to cure something. So these are the 5 interventions, just in case you don't remember that from Basic Medical Science 101. Diagnostic, preventive, curative, rehabilitative, and palliative. And I added educative because I'm actually part of the Institute of Health Sciences Education, which does research on how to educate health professionals. So then you have, what is the intervention? You know, is it a genetic intervention, a pharmacological, a surgical, a physical, a behavioral, a technological, or a thinking intervention? Then you have to say, who's my target? Is it the patient? And now, is this a uniform group of patients, or is this a diverse on purpose? You know, because some research, you need to have a diverse group of patients, not hothouse tomatoes that are absolutely perfect. Does my intervention also impact the care partner? Or is my intervention targeting a member of the public, or a health professional, or the health system? What's the context? Is it a clinical context? Is this a community context? Is this a public health context? Am I doing this in a health institution, health services, or a school, an educational facility? And what are my outcomes? And these are the outcomes: mortality, morbidity, symptoms, function, health-related quality of life, cost, knowledge, skills, attitude, satisfaction, and experiences. So you can see we're far away from a pharmaceutical intervention that has a single molecule delivered on a standard protocol with a placebo, and we're targeting something in the blood that is measured without error. So this is why we need different paradigms. So to be effective, a complex intervention has to demonstrate that the components, of which there are several, are effective in everyday practice and everyday life. They don't just work in the lab. They have to be able to be rolled out in the real world setting. You have to demonstrate the whole range of effects and how they vary among recipients between the different sites. So you have to demonstrate the range of effects. You don't have just one. You have to say, well, you know, I'll give you some examples of showing the range of effects. And it has to be, you have to demonstrate that it works across sites if you have a multi-site trial. And you have to demonstrate how the intervention works. We're not delivering black boxes to patients. We have to understand what are the active ingredients and how they are exerting their effect. So you understand from a pharmaceutical trial, they've done all that in the lab. They've done it in a petri dish, and then they've done it in a mouse. But we don't have that luxury when you're doing a complex intervention, because it has got very many moving parts. So here's some examples of what would be called a complex intervention. Anything community-based, anything that's a group-based program or a school-based program. Clinical teams, if you're evaluating team-based approach, and there's many historical and current examples of putting in clinical teams. Clinical units, there are sometimes, you know, different units, stroke units, TBI units, intensive care units. CBT, cognitive behavioral therapy, is a complex intervention. Hospital at home, service delivery interventions, healthcare professional behavioral interventions, health promotion activities, digital health technologies are complex, and I'll show you an example. And obviously rehabilitation is complex. So these are some examples. So what's different about a different paradigm in this world is that the people you're targeting are actually going to develop your intervention, because you're trying to improve them. Well, they know better than you. So you actually have to engage this group of people to help you design the intervention. Because if you're trying to fix them, you need to fix what they need fixing, not your favorite pet thing. It's not about you, it's about them. So they help with the intervention. And we have many, many examples. And I know that this institution does a lot of, you know, work with patient partners. They help you with the intervention. And when you go to evaluate the intervention, you evaluate it on them. So it'll work better because they've told you what they need and you evaluate it on them. That's a different paradigm than our standard. My favorite element is being evaluated on these people. That's the standard non-complex intervention. I mean, sometimes, they want to call it simple, but I don't think any trial is simple. So I don't think we should call it a simple intervention. I think it's just non-complex. Here, it's very standard. I have my favorite thing. If I'm a drug company, I have my molecule and I'm evaluating. And my interest is on my molecule. When you're dealing with this complex intervention and you're trying to impact on these people, they have to have input into what they want done. So that's why you need a different paradigm. So while the intervention is complex to design, what the control group gets is even trickier. It's much easier to get people to tell you what they want. How you pick a control group is a nightmare. And the study that we were talking about with Helen when I first met her, we actually had this big meeting about the control group, not about the intervention. The intervention is easy. We're going to do X, Y, Z. And it's fine. There's no problem. We've done the legwork and people had told us what they wanted and what they would do. And we designed it for their needs. We couldn't figure out what the control group was going to get. So here are your choices. They could get nothing. All right, fine. They could get usual care. Nothing is easy to define, except that you may not know what they get. Nothing may be nothing that you know about, but they may be getting all sorts of secret things that you don't know about. Usual care is highly variable. And I actually have in multiple sclerosis a colleague who's documenting usual care across trials of multiple sclerosis to say what did they actually get. So usual care is highly, highly variable. You can't do a placebo because there are no placebos for complex interventions because there's a million moving parts. You can't do a sham because, again, what would you sham? What about an active alternative? So you could give your super duper and then you could give knitting or, I don't know, looking at YouTube videos. It's tricky. You have to think long and hard about the control intervention. The other way of looking at it is you could give a big stick or some little sticks or lesser sticks. That's often done. It's actually called a dismantling trial. Give the big intervention and then just give a small piece of it. That's often done in implementation science when they're implementing complex things in healthcare systems. You get the everything and this just gets the pocket card or the health. So these are things that you have to think about when you have a complex intervention by definition. So with these interventions, you have to be very specific about what you're delivering because otherwise it's not reproducible. Now, fortunately, we have something called the TIDER guidelines, and they're in Equator. Equator is the big guideline place. So it's called Template for Intervention Description and Replication, and they have a checklist. And when you submit a trial that is of an intervention that's not a drug, you have to fill out this whole checklist. And you have to say, what page have you described this on? So you have to name it, why it, what equipment is needed, who provides it, how and where is it provided, when and how much, tailoring, how well was it provided, what is your adherence and fidelity. So these are TIDER guidelines. And so you have to fill out this complicated thing. And it's really important to look at it before you design your study, because in fact, you can design your study and fill in all those boxes at your protocol stage to make sure that you've collected the data. And when I write trials, I just throw frameworks at all of the funding agency to say, I'm using this framework, this framework, this framework, this framework. Don't fight with me, fight with them. These people told you have to do that. I do that. It's a safety net. I say, we followed TIDER guidelines, or we followed this. So complex interventions are by definition patient-centered. So I don't know how much this has come into the UK, but I hate to talk about the United States, especially since we're Canadian right now, we're kind of allergic, but they have a whole institution called the Patient-Centered Outcomes Research Institute, PCORI, and they fund a lot of patient-centered. So patient-centered outcomes are apart from mortality, symptoms, function, and quality of life. That's what patients care about. Obviously, they care about mortality. It also needs to provide meaningful evidence to the different actors in the healthcare process. So if you improve a patient-centered outcome, but don't change anything that's clinically relevant, this is a problem. Nobody will believe your intervention. They'll say, oh, it's just a placebo effect or regression to the mean or it's response shift. So you can't just have patient-centered outcomes. You have to have the whole spectrum of outcomes. So all of the stakeholders in the intervention have something that they think is important in the clinical pathway. So that means you have to have different sources of information on the outcomes. You can't just have one source, the patient or the clinician. So there's another taxonomy, and this is largely based on FDA, Food and Drug Administration. This is kind of their terminology, but I wrote the paper on it. And it's essentially terminology to measure what matters in health. And so the jargon is a patient-reported outcome, and I'm sure you've all heard PROs, patient-reported outcome, and that is something that only the patient can report, the person can report, and it can't be interpreted by anybody else. So how tired are you? So you say, oh, I'm very tired. I can't say, no, you're not. You're not tired. Of course I can't say. You say you're tired, you're tired. So those are patient-reported outcomes. If you're in pain, you're in pain. I can't say you don't have pain. Self-report outcomes are a little bit different in that you could verify. So the example I like to give, how well do you drive a car? I might test that. So after stroke, somebody's had a stroke, I have no problem driving a car. I might test it. So it can be that, it can be verified. But the patient can self-report, but you might verify it in certain circumstances. Can you go upstairs? Yes, I have no problem. Yeah, sure. Usually if the patient says they can't do it, they can't do it. But if they say they can do it, you might verify. So we have many self-report. Do you have how much difficulty do you have walking a mile, going upstairs? These are called self-report. I could verify it. And we have a lot of self-report, more than PROs. An observed row is something that an observer does. So if you go into the hospital and the nurse fills out a Bartell form, the nurse, observes you, can the person brush their teeth? That's an observer. It could be, for example, a parent, or if you have an older person, somebody that knows the person well. A clin row is filled out by a clinician, and we have many, many examples of that. And I have to say, they really do not work. They take things that are measured and rated. So, for example, we've done one for ataxia, and this is a test. So instead of counting, they count it. But if you pass a certain number, you get 0.5. If you get more of a number, you get 1. Well, just count it, 14. How many correct? 11. They don't. They rate the measure. And, it's hugely subjected to, thousands of pieces of error. Clin rows are, unfortunately, are the ones that are qualified in most clinical situations. No kidding. People have vested interest in being the expert, but they're usually not things that are patient-centered. Patient doesn't really care about this or whether they can do this. They don't really care about that. It's not functional. It tells you what the brain is doing, but it's not usually patient-centered. Those are called clin rows. They're clinically reported. We have performance rows. We talked earlier, 6-minute walk test at the performance. And we have tech rows, which are ones that are collected through technology. For example, your smartphone will tell you steps per day. We just showed you technology in our workshop, which gives you kinematic data. So those are tech roles. So that's the portfolio. So here's some non-complex and complex intervention models. So the most non-complex, you have an intervention that targets one outcome. That's it. The rest of the outcomes may contribute, but they don't provide evidentiary support. It's only the one outcome. So you have to think, how much do we have that? You may measure outcomes because you're going to look under other things, but the evidence is based on that changing one outcome. So that's usually the pharmacological model. I'm targeting this drug, I'm changing this protein. The domino effect is I fix this and everything falls magically into place. This is the key. The other outcomes can show relevance. They're relevant. Oh, good, I got this. But again, they do not provide evidentiary support. Complex interventions tend to be a fan. They target lots of things simultaneously, and each contributes evidentiary support. Challenge is how do you summarize that into one piece of evidence? So you have to think about your models. And when I teach it, or people have, studies coming to see me about, we say, is it a target? Is it a domino, or is it a fan? And that, changes your outcomes and how you present your outcomes. So this should resonate with you providing different interventions. The other thing that a complex intervention requires is a strong measurement model, because you won't know what to measure unless you have a strong measurement model. Here's just a few. There's lots. You don't have to use these. One of the best known in the rehabilitation world, of course, is the ICF, which is at the bottom. So that tells you have to measure, body structure and function, activities, participation. You have to consider context, environmental factors, personal factors, as confounders. The other one, which is a more of a medical model, is the Wilson-Cleary model, which is the one in blue. And it was developed to get medical people thinking beyond the molecule and beyond the symptom or the biological effect. And it shows, there's a physiological and biological effects, there's symptoms, there's function, there's health perception, and there's quality of life. And it's influenced by characteristics of the patient. And you can see things like symptom amplification and personality and preferences. Patient preferences come into that. And the environment is also lots of stuff. So this was, and I know this Wilson, Paul Wilson, and so Paul Cleary and Ira Wilson, they said it's not perfect. They don't know where mental health fits, so they just made it up. But it really was an important feature in 1995 that brought the medical world into outcomes that matter to patients. So the other model that I like, and I learned this actually from working with Helen, and she had used this model, it's called the COMPI model, and it has, you measure capability, you measure motivational factors, you measure opportunity, but your aim is to change behavior, but you also recognize it bidirectional, that your behavioral change can improve your capability, right? And your motivation. So I like that model. I published a bit on it. But it doesn't matter. It just, you have to have some sort of model to inform your measurement strategy. And so when you write your grant, you say that the measurement framework for this study was informed by the blah, blah model. So nobody can fight with you unless they hate your model. But I mean, half the time the reviewers wouldn't know a model if they fell over it on the street. So you say, oh, okay, oh my God, they have a model. All right, good. So you need to have a model if you're doing anything that's complex. So one of the challenges with complex interventions is you're trying to put a square peg into a round hole. You're trying to take the square peg of a complex intervention with all its moving parts and stick it into that randomized trial design that you learned in Research Methods 101. And it doesn't fit. That one ingredient trial, one outcome, randomization measured without error and no confounding. So the British Medical Journal has led in this complex intervention. So don't have to put all those words. You can look it up if you're ever doing it. And if you're writing a complex intervention, you say, using this model. And they can't necessarily fight it. So essentially it says, we need to fix this problem, and it's complex, and a single molecule on a spoon is not going to be successful. So you have to have some theory that is related to the outcomes you're trying to improve. You probably need to have some observational data that there's a problem and that you can model it. So that's always good if you have a database that you can look at or some other data. You have to do this kind of exploratory pilot trial to get some data that it's feasible and you will get a signal. And then you do your definitive trial, and then you have to implement. Some of these phases, particularly the last two, can be combined into a design that's called a hybrid design. And it incorporates, and I'll name that a little later. It incorporates both the definitive trial and the implementation in one trial. It's called a hybrid design. So here are the steps that we've talked about. So what theories apply to inform the intervention? What do people living with the target health situation say needs to be done? So that's the participatory part. What observations support your hypothesis? If you haven't seen this in the real world, it could even be qualitative data. It doesn't have to be necessarily all math, but you need to have some support that we've seen this, it exists. You need a proof of concept or a pilot study. You need to have a study that's adequately powered for all the outcomes that are contributing evidence. You have to have an implementation plan. So what? Now what? You can't just do an intervention that sits in a nice journal article that you put on your coffee table. It has to be implementable. And you have to find out from the participants their experience with the intervention, and that's exit debriefing. You need to build that into the protocol so you understand how you think mathematically it worked and how the patients tell you it worked. Otherwise, you'll have a big mismatch between what you thought happened and what the patients thought happened. So these are sort of the steps. So I'm going to give you some real life examples. So this is actually from a New England Journal of Medicine article, and it was linking intervention to its effect. And it was from this article, multifactorial intervention, cardiovascular disease in patients with type 2 diabetes. The reason I'm presenting it is it's from the New England Journal of Medicine, and I don't know whether you salivate over the NEJM here, but certainly in North America, we all do. And I had the privilege of traveling with the editor of the New England Journal to China, and I presented this as a teaching example when I was in China. And here's the question. So if you know anything about research, you'll know the PICO question. So they didn't have a PICO question because they're above that, but I made them a PICO question. Among people with type 2 diabetes and microalbuminuria, does intensified targeted multifactorial management, talk about complex, compared to conventional care, whatever that is, reduce mortality from cardiovascular causes and occurrence of MI, coronary artery procedure, stroke, amputation, blah, 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 blah. You see, there's not one outcome. So that was my PICO question. And this was actually their model. They did not have a model. But what they had to do was these arrows show the tables they produced. So based on what they produced, I redesigned their study book. So they had intensive key team management, which changed the behavior in subjects and in the clinicians, which produced favorable changes in the biomarkers, which had the better outcomes. So they did not have that path. What they presented was table 1 was the first black upside down arrow. Table 1 was who they are, they're people. Table 2 was how it affected behavior. Table 3 was how did the intervention have an impact on the biomarkers, and then table 4 was how did it affect outcomes. So they had the wrong model. They analyzed it regression on regression on regression on regression. So they regressed the behavior change, the Y, behavior change on team management. Then they regressed biomarkers on team management. And then they regressed outcomes on team management. This would have been a structural equation model. This is a complex intervention. You need to model that as a structural equation model, not as this regression on regression on regression. So you can see they had a complex intervention that they tried to treat as a bunch of simple interventions. But it's a good model to understand that, there was a process. This was a very complex intervention with multiple phases and multiple things. And what happened with the control group, there was no behavior change in the clinicians. The clinicians didn't change their behavior. So, can you imagine implementing? There's a lot of rich data, of course, that they didn't maximize on it. So that was an example. So as you see, there's multiple outcomes here. So I don't know how many of you, when you do your trials, primary outcome, secondary outcome, tertiary outcome, quaternary, have to have something better than the numbers to understand how these outcomes fit into the causal pathway. So one, better than 1, 2, 3. This is a very good model. It's actually from a statistician from University of Colorado. So I label my outcomes as confirmatory. What am I confirming my trial? And that's, and the reason that's important because I'm designing the intervention to impact one thing. So it's got to have the right ingredients on the spoon to affect that. But I need explanatory outcomes. How on earth did that happen? How did I get this wonderful outcome? Or more importantly, how did I not get it? What happens if I didn't get it? What happened? So that's an explanatory outcome. So you can say an explanatory outcome. Then we have exploratory outcome. Well, what else happened? Did it impact on the caregiver? Did it impact on quality of life? Did it impact on blah, blah, services we want? Those are exploratory. Now, the power that you're going to put into your study for all of these needs to be considered, but it mustn't drive the power. So you can't have a study that needs 40 people per group for the confirmatory and 200 for the exploratory. That would not fly. So you have to consider the power. You can power it a little bit less, but these do not drive the power calculation. But you can't ignore them, and you need to have them in a complex intervention. What else? So here's a complex intervention. This is an old study I did. It's called There's No Place Like Home. Early supported discharge. This was done in a time where the average length of stay for stroke in Canada was 30 days. Spending a month in hospital, God knows the price was huge by then. So the PICO question was, among people ready for discharge from hospital after an acute stroke, to what extent does prompt discharge combined with 4 weeks of home rehab in comparison to the usual discharge pattern impact on health-related quality of life, community reintegration and function 3 months after stroke? So the primary hypothesis was that in comparison to usual care, home rehab would shorten lengths of hospital stay and enhance quality of life and community reintegration without a detrimental effect. Because we're taking people out of the hospital where they get stroke physiotherapists and occupational therapists and speech therapists hovering about them for 30 days, and I sent them home. Would I get better sort of behavioral outcome, but with a detriment to function? So would I get better function without recovery? So there's a check mark saying it worked, and we didn't get those. We got function. And then the second question, would the intervention cost less and not impose extra burden to caregivers? So you can imagine somebody who's stroke staying in the hospital for 30 days. By the time they get home, they're very robust, right? They have 30 days. Now they stay in hospital 2 days, so don't need to stay in hospital. So we had to make sure that we weren't just shoving the burden of care from the hospital to the poor caregiver, who could be anybody. So that was our secondary outcome, and there's a check mark because we showed that. But what I want to show you is what was on the spoon. That's a thing I use all the time with interventions. What's on your spoon? What do you have on your spoon that could possibly change the outcome? And it comes from, if your kid is sick, you give them grape or banana flavored amoxicillin. It's not the grape and it's not the banana. It's the amoxicillin. You have to have something on your spoon that is potent enough to change your outcome. So this is what we had. We had 65, 60 people in each group. In the home rehab, they stayed on average 9 days in hospital, whereas the usual care stayed 12. But then they spend another month in rehab, whereas we spent 0 days in rehab. So you can see the cost benefit already. They had a total of 9 days of care, and these people had a total average of 16 days. So they had, 7 more days. They got 6 physical in the month. They got 6 physical therapy visits, 9 OT, nursing, and the percent of people with visits. This is after discharge. So I didn't count what happened here. I just count once they left the hospital. So they did go for a bit of outpatient care. They had a bit of visits, but 100% of our people had visits, whereas only 52% in the usual care had any visits. So you already see what I'm delivering on the spoon here. And this is what it cost. So it cost me, the intervention group, almost $8,000 up until 3 months. And in the usual care, it cost me $11,000. And my caregiver burden was actually less than it was in the hospital. So the intervention was complex because it required people get discharged from the hospital. The team went into the hospital, and it could have been anybody. It was usually, sometimes it was the OT that went in first. They had whatever they needed. Some had speech, some had physio, some had nutrition, some had whatever. It was tailored. It's not one size fits all. Some people had more nursing visits. So this is a complex intervention. And that just showed we did have the one outcome, but we measured the other outcomes as part of the evidence. So when we did our exit debrief, usual care group was mad at us. They were angry because they got nothing. They essentially, many people got nothing. Half of the people got no business. So that affected the desire to be assessed. They didn't want it. Why should I come in for the assessment? You gave me nothing. So we also noticed that the therapist said, once the participation at home, there was a power shift from the clinical team to the family, which was favorable. They noticed it. Suddenly, you're a guest in their house. They're driving the bus. And that changed empowerment. And the caregivers felt, this is reception from there. They felt empowered to take charge of what needed to be done. So suddenly they were problem solving. We're bringing the bed downstairs. We're getting rid of this carpet. This is stupid. We're not having this, this piece of furniture. We have no railing to go down the stairs. Dad wants to go down to the patio, so we're building a railing. And the nurse knows that if the patient was medically unstable, she had no one to contact. There was no one to help. So the family physician did not want to manage a stroke 7 days post-stroke. They were used to getting a patient a month after stroke. Now they were getting 7 days post-stroke. They had no idea what to do. Oh my God, you know what they say? Send them to emerge. Send them to emerge. Now I had a bunch of docs on my grant, and I would phone them up and they'd say, okay, I'll see them. But this is not what happens in the real world, right? Because in the real world, they go to the emergency and they wait 2 days before anybody sees them. So the issue of optimal stroke care was not solved. So what did we have to do next? We had to do this study on bridging the gap, the effectiveness of teaming a stroke coordinator with a personal physician. So that was the next thing. Now, make a long story short, you can read about the article if you're interested. We chose very messy people. We chose everybody that needed stroke coordination. And we took people that needed social services. We took people that, were cognitively affected. We took people with dysphagia, incontinence. We took a messy group of people. That's who needs case management. And we found it didn't make a difference. There was no effect. So then we looked and said, what did the people get? So we did a study on what they got. And we actually found they got a million things, but none of them affected physical function. So our outcome was physical function, because guess what? It's stroke. That's the outcome, not these strange things. So what was delivered on the spoon was actually nothing to do with physical function. So we recreated our outcome. There 50 different interventions, all depended on need, range of 2 to 15, talk about tailoring. So we found that each patient was unique, requiring a high degree of tailoring. Some people only had swallowing problems. Some people had speech. Some people had, food insecurity. The classic stroke was rare. So we wrote this paper. Evaluating a complex intervention with a single outcome may not be a good idea, and it's not. We created a way of combining the data into a composite outcome using a statistical model, generalized estimating equations, where you have, so we didn't pick, there was nothing on the spoon that affected motor. We had the SF36, I'll just show you that. We had the SF36, which has 8 subscales, including physical function. We only reported on 7. So if you look at the proportion making a clinically meaningful change, nothing is impressive. 50 versus 44, 28 versus 26, 50. Always a little bit, but not powered for anyone. But when you put it together as a complex outcome, you get a lot of power benefit for having more than outcome. And the odds ratio is 1.43, and it's significant. It meant that the case management group was 43% more likely to have a favorable outcome than the control group, no matter what you call outcome. And that's using a model for your complex interventions. So that's another thing that you can do. And I think we have the right answer now. Discovery consists of seeing what everybody else has seen and thinking what no one else has. So you have to think outside of the box. So here's something a bit more modern. This is a health technology assessment, and this is why I want, because you guys do a lot of digital health, so I want to, talk about digital health as a complex intervention. Because having a thing, and I was just giving a workshop on a thing, having a thing, here's my thing here, having a thing is not enough. It's not enough just to have a thing, because you have to think of the usability of the thing. Its aesthetics, its design, its functionality, its complexity. You have to think of the person. Are they tech ready? What are their attitudes to having a thing? What are their skills? How useful do they think this is? How easy is it to use? So this makes this simple thing very complex, because you have to negotiate this terrain. So you need to understand why wonderful people do not adopt your wonderful thing. It's wonderful, but the people don't adopt it. Why not? So yeah, you have to have these solutions to this non-adoption of wonderful things. So what are the external variables? Is there a perceived usefulness? Is there a perceived ease of use? What is your attitude, behavior intention, and actual system use? So your technology is actually a fairly nightmarish type activity, intervention, which you need a complex thing. So we're not going to do that. We just did, this is our Parkinson's trial. So we wanted to take our evidence from Parkinson's and move it into dementia. So if I'm moving it into another condition, what do I need? Well, I need theory, I need data, observational data, I need target users input. I need input from target users and the patients. I need that know of the intervention and the control. I need proof of concept. But evidence that tech improves walking is not enough. In dementia, you have to have a cognitive impact. People don't care about whether the person with dementia can walk. You might, but the healthcare system does not. They don't care about walking. They care about the mini mental or the MOCA or some cognitive test. So we had to do this trial on tech. And what this is called, there's another framework that you can use. It's called the ADAPT. It's adapting interventions to new contexts. This is the ADAPT guidance. So we had done a trial in Parkinson's. I had to adapt it now to dementia. So this is another framework that you can use. So you have to have a model. We had a model. You don't have to look at the details, but cognitive impairment affects gait kinematics, affects strength, it affects falls, it affects walking capacity, and it's all fed back. So we had a model to say we want to intervene at the level of gait kinematics. That's where we're intervening. We had to have a question. We had no control group. What is the control group going to get? No idea. Tech is not enough. They have to get everything but the sensor. And so this was the design. They got this workbook and this person got the agenda. This person got the sensor, but the outcome had to be cognition and its effect on the downstream outcome. So that was that was the thinking of this complex intervention. So then we were able to write the question. So if you have complex interventions, you have complex groups, you have complex patient goals, you have outcomes, and you have time points. So if you have more than two groups, so the standard clinical trial usually has two groups. You have more than two groups. You have to think about using orthogonal contrast, or you pay the price. You can't compare group 4 to group 1, group 3 to group 1, group 2 to group 1. They're non-independent comparisons. Got a problem with group 1, you're dead. If group 1 by chance is weird, you're in a lot of trouble. So orthogonal contrasts, or you pay the price, you have to adjust the p-value, and they're non-independent, so you may have a big problem. So you probably learned orthogonal contrast in Psych 101. You've got 4 groups, you compare, any intervention to none. You have 4 groups, you get 3 independent comparisons. Now, if you're not meeting the patient's goals with your input, you're not going to get anywhere with your trial. So we have to know, why did the patient enter the trial? The patient entered the trial because they wanted to change something. Yes, they wanted to be altruistic. So goals are always survival and feel, function, and survive. And there's no one size fits all outcome. So these are your outcome choices. A qualified COA, which is what you can license your drug on. You can have an accepted COA, which is like what everybody uses, 6-minute walk test, Bartel, PROMIS, SF36, whatever. Or you can have a new COA, a new measure, and you have to cover the spectrum of patient-reported outcomes, self-reported, perf rows, tech rows. You'll usually have a CLIN row in there. So your outcomes have to be very rich. And usually you have to have more time points. So if you only have one time point, your outcome is an event, death, incidence of stroke, or an event, fall. If you have 2 points, you can only measure change, which is extraordinarily boring because you took your longitudinal study and made it cross-section. If you have 3 time points, you can measure linear growth, but you can't. But if you have 4 points, you can measure non-linear trajectories, and 4 points are probably needed for your complex intervention because you need to be able to look at it in a non-linear fashion. So that's why it's complex. So I'm going to give you an example. This is a study that just went in. Can priming enhance rehabilitation success in progressive MS? This is the Can Prime MS trial, and Helen, if we get it, is going to be on it. So we have priming, primer A, primer B, 2 primers together or needed by 4 groups. Why did people enter the trial? Some people entered it because they had cognitive problems. Some people entered it because they have arm problems, and some because of mobility. So the cognitive people, are we going to put them on treadmill? Are we going to teach them 6-minute walking? The arm people, are they going to do the cognitive test? No, you have to tailor it to what they came in for. So the cognitive people with cognitive goals are getting cognitive therapy. The people that came in with arm problems are getting arm therapy, and the people that came in with mobility are getting mobility. So I can't have one outcome. So we've picked 2 accepted COAs, both all performance for each. 2 for cognitive, 2 for arm, 2 for leg. We're going to Z-score them and add them up. So everybody gets a score that is interpretable on the same scale. They get 1, but it happens to be different for each person. The qualified COA reflects the brain. It is not a person-centered. This trial in particular wanted to make sure that it was relevant to the patient. So we're going to measure them and put them in as explanatory. How did we get our wonderful outcomes? Do we have those regular boring things? And then what are we going to do with our time points? And I wanted 4 because it inflates my sample size by a factor of 1.4. And progressive MS is a rare condition, fortunately. And if you can't get enough people, get more measures or get more time points. So we chose more time points. So we have much more usable data with 4 time points. So that is the thinking behind a complex intervention. So just to summarize, the lessons learned from these early things is complex interventions. First, they're difficult to mask from the participant because in the absence of amnesia, the patient knew which group they got. The nurse is coming to my house. I think I'm in the nurse group. You need to have a range of outcomes that reflect the person's perspective, as well as those unaffected by unmasking. Because as much as you want to mask your evaluator, they can always guess. You need to ask them, did you know what group they were in? If not, can you guess? But you need an outcome that is not affected by unmasking, like the 6-minute walk test. Or something that isn't matter whether the therapist knows what group you're in or the evaluator. And that's why tech is amazing, because there's nothing that anybody can do to affect tech. That's good. So the rules of interventions is you have to have something in order not to bias the results that is equally attractive to the naive observer. So what I do is I write the consent form first. If I'm designing a trial, I write the consent form. How can I get somebody into my trial without giving away the whole hypothesis? Because if they know there's a bad group, they won't be in it. And you'll randomize them and they'll drop out. And you'll have on your consort diagram dropouts before, after randomization and before intervention. And that's really a problem because there's nothing you can do to impute that missing data. I usually try and word my study as comparative effectiveness. We don't know which works better for whom. Some people do better with whatever, others with whatever. We need to know what works better for whoever, because the minute you've written your protocol has to go into consent form. So I rewrite my protocol to make sure I can get people into my study. I also describe the control group first, and I make it look as wonderful as possible, and I make the intervention look like a pain in the neck. And then they're not sad if they get into the in the control group. And if I can't write the consent form, I'm not getting anybody in my study. If I can't make it look interesting. Don't use a single outcome. It will not answer your question. And there's lots of alternate designs that can be used for complex interventions. Explanatory, pragmatic, pilot studies, dismantling, that's like hit it with a big stick and then hit it with little sticks. A trial within a trial, you can actually randomize, double randomize. Trial within a cohort, you can have a cohort. You can identify people that need to trial, you can trial them. Hybrid, as I said, is the effectiveness and the implementation. An adaptive trial adapts if you have imbalance in your study, and there's lots more. You probably know the clustered one, you probably know step wedge. There's a bunch of interesting ones, the basket, the platform, the umbrella, and these are called master protocol ones. There's a master protocol. And for example, the platform trial, we're doing one in Montreal now that I'm helping with. And essentially, you test a whole bunch of interventions. And if one fails, you get those people out of that intervention and stick them in the other intervention. Problem with it is you need an outcome that's quickly responsive. You can't wait 2 years. You think in 2 years, woman. So it works very well. These are often done in oncology because you can look at tumor response quite quickly. We have to adapt them a bit to our rehab ones. Sequential, time series, N of 1, blah, blah, blah. So there's some literature on complex interventions. The ADAPT, the Equator has 1 million reporting guidelines, Tidier, and reporting, from the consort. And I think what, why, where, and how. I think interventions with many, what is interventions with many intersecting components? Why? Because you need to meet the complex and varied needs of real people. That's why you have to do it. How is you have to have this theory, these observations, where you can do it anywhere. And many trials of complexity are going virtual, which will add another layer of complexity. And I think we can do this, so we should. So thank you for asking me to make this talk. Thank you. Comments, questions? Anybody got a complex intervention? Why, yeah, that's. You have a complex intervention. Doing home care rehab. Yeah, and there's a lot of pieces in there. Anybody else doing complex? Helen, that's all uniquely complex intervention.
That's terrible. And I can share, we did one study where, for the recruitment and just the funds, and we did a study with Parkinson's study intervention we were interested in, an exercise intervention, but we created this control group, which was it was kind of like hand function, and it turns out people with Parkinson's are really, really much more interested in that and solve that. So we actually have written the study up as 2 trials in one study. And the handwork is like about study.
Yeah.
So I think it really works, and we recruited like crazy, and they all put control on to the exercise.
Yeah. We did a study in rehabilitation for colorectal surgery, and we knew what the control intervention group was going to get. They were going to go to our gym, our prehab clinic, and they were going to, do the VO2 max, and they were going to have exercise and bicycles and weights and blah, blah, blah. And we went, what on earth are we going to give the control group? So I went, well, in my day as physio, we used to do pre and post-op reading. So, and, foot and ankle and, whatever. So I said, let's give the control group that and then tell them to do a bit of walking. The control group did much better than the intervention group. And my clinical colleagues know that one group did better than the other, but they have forgotten which one. So they go around telling us how wonderful prehab is for colorectal cancer. But in fact, it was the control group that did that. So that was an example of something very complex and simple with that. I mean, we have multiple examples. We had another one with our stroke. We wanted to do arm and leg, and I had 2 PhDs. So we randomized patients to get arm therapy or leg therapy. And so the arm people, the control group was the leg, and the leg people, the control group was the arm. So the mobility people, we did a lot of work on the treadmills. Should have seen what happened to grip strength. What do you people hanging on a dear life on the treadmill? We had a signal on grip strength in the mobility system. We were hanging on to the treadmill. So yeah, what a mess. But good, and it needs to be that. Yeah.
There's a question online. Chris Fox asked if you've got any views on goal attainment.
Yes.
Trial outcomes in messy trials, for example, sleep.
Shall I ask it in reality? Because
Yes,
I'm just
sure,
outside
sure.
RAF.
Yeah,
And I'm in Norfolk, so this is why it's a bit weird. So we've just completed a very messy trial in sleep and dementia, and every single outcome has failed. So we're now thinking of moving into rehab goal attainment because
Yeah.
sleep is very complex. You can have too much, too little, nightmares, and none of the measures, they're all useless. But I wondered if you had any views on that. There's something called the gaslight, the banger. There's ones for dementia, but you have to give it to the active group and the intervention group, so it's a selling point in a way to your control. But I'd be interested in any thoughts.
yeah. So I know goal attainment scaling very well. I know Ken Rockwood. We've used it. I don't like its ordinal scale as an outcome. I like the concept of goals. So for example, with the trial I just showed you, we are asking them the goals, but we're using the COPM, which is the Canadian Occupational Performance Measure. It asks people what their goals are, and it asks them to rate it on a 10-point scale and blah, blah, blah. That's a little bit better than Ken Rockwood's ordinal scale, which he doesn't really analyze as an ordinal outcome, which is a bit of a nightmare to do. The other one I use is the patient-generated index. It asks, it's called a personalized measure. It asks people, name 5 areas where your condition is affecting your life. And so then they rate it on, this is the best it could be or the worst. And then they preference it. They say, if you had things, 10 points to spend to improve that, what would you improve? And that gives you a target. And I think that might help you, because if you don't say how sleep is affected, you like to say, what are the 5 most annoying aspects of your sleep? Then they might say having a nightmare. Somebody else may say waking up and not getting back to sleep. Somebody else may say, I don't know, whatever. But then that's their outcome. And then that's measured on preference points, and it's measured on visual analog scale. So I think it's better than Ken's ordinal scale. Met above exceeds expectation, meets expectations, 0, 0, didn't meet it, and I know he doesn't use it as an ordinal scale because I don't think he went to that class on ordinal outcomes. If he missed that. So I like the patient-generated index. So yeah, your answer is yes, use goals.
And I would reinforce what Nancy said, because we did a goal, I don't know if Chris can hear me, a goal attainment scaling in a trial. I think it was brain injury or stroke. And we found that with researchers, they got the goals wrong because they didn't know the patients. So the way it's scored, it was just a disaster because they set the wrong goal.
Yeah.
So whereas clinicians, I think a lot of the work's been with clinical teams, and then they set appropriate goals.
Yeah. So with goal setting, you have to decide whether you're doing collaborative goals or individualized goals. So most of the goal setting stuff is collaborative, where the patient works with the therapist to set a goal. When you use the PGI, it is the patient's, but it's not so much a goal, it's what's bothering them. It's that this is what's bothering me. Waking up at night, then that's their outcome.
We can share those papers, Chris.
Yeah, I use the PGI also.
I can assume sometimes the trial, the intervention could be very simple, but in practice could be very complex.
Yes.
For example, we just having and you will try to support a trial just for 3 minutes.
Yes.
For the osteoarthritis.
Yes.
Looks very simple.
Yes.
But however,
Yeah.
many patients prefer to be in the intervention group
Yes.
rather than in the control group.
Yes.
Instead. Then the sponsor of the project said, is it possible to say at the end of the trial, if the patients stay in the control group, they might have a free device at the end for the intervention. I wonder if it's acceptable.
Absolutely, it is. We often do that.
Yeah, can I give the patient some incentive?
Yeah. So when we do our trials with our center, they get to keep it.
I know, okay.
Yeah, they get to keep it.
Already acceptable.
Yeah, but I think, like it appears to be, relatively simple, but it's a tech. There's technology involved.
Okay.
So, they have to like the technology, they have to believe in it. Whereas if you have an intervention that, essentially is you go to a physiotherapy for knee therapy, they kind of have space validity for the person. They kind of go, oh, I'm going to see the expert, right? But when you give them a piece of tech, that's why it's complex. They have to believe in it. They have to think it's going to work. They have to use it. It has to be simple to use. So it becomes a little bit more complex. And then you have adherence.
Yeah.
Because you want them to do X number of legs, but they might do Y. So you have to do that. And so it becomes complex. And then, a simple thing like knee osteoarthritis, there's a million outcomes. What is the outcome? Is it pain? That's terrible. It's subjective response. That's, is it cartilage, with the joint space? Is it the oswestry? Is it the cools, the knee thing? Not the knee outcome thing? Is it the 6-minute walk test? Is it, going upstairs? Is it promise? Is it help lay quality of life? So the thing is that you probably don't know what the impact is. You might have an impact because you're a surgeon and you want this, but you would have to measure all of those outcomes and have an analytical strategy for having a whole bunch of hierarchically linked outcomes.
This is why the surgeons and the design and nurses, they fight against each other.
Yes.
It's outcomes.
Yeah,
But at the end of the day, we did choose the aim and the function.
Yeah.
Otherwise, it would be very.
yeah. But you see, that's why it was complex. It's more complex than you think.
Yeah.
Because of all of these outcomes.
Thank you very much.
I'm slightly aware of time. Has anyone got a burning question or, if not, if I can close now, then maybe you can come and ask Nancy afterwards. So, thank you. That, as always, totally fabulous. And I'm sure everybody's now going to run off home and think about lots of trial design. So that's been really, really helpful. And I guess if people want to contact Nancy, maybe come through me so that, or they can contact you direct. Yeah.
Send me, I get 300 a day, so don't be worried if I ignore you, just send it again.
Okay. Perfect. So thank you very much. So just say and thank you to everyone online. Okay.
Great, it was nice meeting everybody. Only design for complex interventions.
Self-distinct.